clock is ticking. Every passing second counts. A possible stroke victim needs help fast. Hartford Hospital's Stroke Center has the team, the technology, and the time-tested protocols to give patients with stroke their best chance to resume normal living.
On three. 1, 2, and 3.
You're at Hartford Hospital, okay?
We're taking you on a stroke victim's journey from the time he or she arrives by air or ground at Hartford Hospital. Stroke Center Coordinator Dawn Beelan says that once the patient gets to the Red Pod section of the emergency department, all hands have already sprung to action.
Once entering the Red Pod, they're quickly assessed by the nursing staff, by the EMS, emergency physician staff, by the neurology staff, to do a quick history and physical, to get their medication history, to do a neuro assessment using the NIH stroke scale, which is a standard acuity scoring system of their severity of their stroke. All those things are done in about 20 minutes.
Can you lift your left leg?
Ready as soon as we...
Okay. Okay. That's good.
The evaluation goes quickly. Is the patient experiencing numbness of the face, arms, or legs? Is he suffering a sudden change in vision? Or is the patient suffering from confusion or having difficulty speaking?
We're running against the clock. There's very good evidence that the quicker we treat patients with whatever intervention we choose, the better their outcome will be. So you saw a lot of people gather very quickly to treat this acute stroke patient.
Once the evaluation is done, it's time to determine what type of stroke the patient has suffered. The patient immediately undergoes a CAT scan.
We're going to move your head up into a cradle here so we can take some pictures.
The answers revealed by the scan will determine the team's course of action.
85% of stroke is what we call ischemic, where an individual blood vessel, either in the neck or in the brain, is blocked off. The other 15% are what we call hemorrhagic stroke, where usually an individual blood vessel ruptures, causing blood to leak out and damage brain tissue in the immediate vicinity of the stroke.
The first treatment that we always will see if the patient is eligible for is intravenous TPA, or the use of thrombolytics. Those need to be given within 3 hours of symptom onset. Another option is intraarterial TPA, where the neurointerventionalists will go into the brain with catheters and deliver the TPA locally at the site of the clot. That can be used out to 6 hours from symptom onset.
The third option is the use of a device called a clot retriever, the so-called Mercy device created by Concentric Medical. That option allows doctors 8 hours from symptom onset to treat the patient. But the stroke team hopes the first earliest option hits the mark.
TPA? Yes. How many kilograms does the patient weigh? 50? Thank you very much. We'll have it in 15 minutes.
The one FDA-approved clot-busting drug called tissue plasminogen activator, or TPA, is given by vein. It is effective in the first 3 hours from onset of stroke symptoms. As one approaches 3 hours, it becomes increasingly less effective in improving patients' recovery from stroke and reducing their disability. That is why it is so critical for people suffering symptoms of stroke to get help fast.
Hey, Dawn, all set.
Thank you very much, Mark. Good luck. Have a great day.
That first line of defense closes quickly.
We really like to stress the importance of using a FAST screen when doing a neuroassessment for stroke. FAST, each letter stands for word. F meaning face, you want to evaluate their face to see if there's any droop. A, evaluate the arms to see if there's any drift in their arms. S stands for speech, to see if there's any abnormalities or changes in their speech. And then T is to note the time of onset, or time to call 911. So FAST is a quick evaluation of their face, arm, speech, and then time of onset to help us determine whether or not this could be a stroke.
Once a diagnosis is made, the options for treating stroke are increasingly varied. Hartford Hospital Stroke Center is equipped with the latest high-tech equipment needed to treat patients suffering from stroke.
Both the certification and the special treatments we offer here in the interventional arena really create a magnetic force for stroke patients to be drawn in to Hartford Hospital for such care.
The Stroke Center is a jointly commissioned certified primary center, the first to receive such a designation in New England as well as Connecticut. Being so means that the center's protocols are based on scientific research. that it's using the national standards of care, that it's using the most up-to-date information to take care of patients and with the most efficiency.
We offer the full scope of care available to acute stroke patients. In fact, all stroke patients, but those patients within a certain window of time can be treated in a manner where their stroke can potentially be effectively cured. These methods are typically catheter-based if a particular patient is not a candidate for intravenous TPA. We have methods here that can restore blood flow to the brain in a rapid fashion and reverse the effects of a stroke.
Hey, so good to see you again.
Very good to see you, Doc.
Yeah.
Once the stroke team determines the patient has had an ischemic stroke, the next step is to determine why. University of Connecticut neurology residents are available on-site 24/7 and have access to vascular neurologist, neurointerventional radiologist, interventional radiologists, and neurosurgeons. It has a CT scan and MRI equipment, angiography suites, and echo labs, all designed to quickly come up with the best ways to treat a patient.
We go over what's happened and then why did this happen. And some of the diagnostic studies that we do to help determine that are an echocardiogram will help us determine if it's a cardioembolic source. Is there a clot in the heart that might have been the source of this ischemia? Or could it have been something in the carotids? The large vessels in our neck over time can get stenosed, maybe from cholesterol or plaque. And we need to determine how open are they? Are they closed? Are they stenotic? Are they fully open and that's not the source? Or could it be something out of the patient's past medical history that might be causing small vessel disease? Things like smoking, years of hypertension, and diabetes are things that could create small vessel disease, and that could be the source of their stroke.
Rehabilitation begins almost immediately for the patient who has suffered a mild stroke on the very day of onset. For 20 to 25% of stroke patients who have severe deficits, rehab may be delayed.
We have a continuum of care from the intensive care unit to the step-down unit and the stroke center to the nurses who deal with the stroke on the floor. And we believe that by providing this continuum of care of specialized services for patients with a stroke, we're improving outcomes and shortening length of stay for these patients. Well, here we admit patients who are very ill, critically ill, and require a higher level of care, whether it is hemodynamic support or they have difficulty with respiration and need to be connected to a ventilator. But also we have neuroscience-trained nurses that can monitor the neurostatus of the patients frequently, and they can alert the physician on any changes in the neurostatus so that we can intervene if needed. We specialize not only patients with an acute ischemic stroke, which is the variety when you don't get enough blood flow to the brain. We also specialize in patients who have hemorrhage, whether it is inside the brain or related to a brain aneurysm. And we are well versed with the management of these patients, particularly those who have complications and require intense monitoring. And so we not only provide support for the stroke, but also other types of neurosurgical patients that may have complex vascular lesions, such as vascular malformations.
Rehabilitation is a part of that continuum of care. It's a link that provides access for patients to all the physicians in the hospital. A consistent plan of care is put in place so that the patient can make the transition from hospital to home and avoid delays to rehabilitation.
When patients come here after a stroke, they have a lot of different issues that they're dealing with. There's emotional issues, there's physical issues, there's psychological issues, communication issues, and we have a team of expert medical and therapy professionals that deal with all those issues.
Hartford Hospital's Rehabilitation Unit is accredited by the Commission on Accreditation of Rehabilitation Facilities. CARF-accredited services have demonstrated a commitment to continually improve the quality of its programs, and its focus is always on patient satisfaction.
It really is a stamp of approval for rehab programs, and we use these standards to continue to improve our program and as guidelines for stroke rehab.
The goal each and every day is to get the patient back home as quickly as possible. The Stroke Center team works to ease the transition.
When we meet with patients, we work directly to answer questions in reference to concerns they have about insurance, making sure that they have adequate coverage to pay their hospital bills, as well as making sure that they have appropriate benefits for their needs once they leave the hospital.
I'm actually going to help you get home sooner. What I need to know from you is, who do you live with? I'll ask them what they do for work. I'll ask them how they feel, if I can get them anything.
The people who make up Hartford Hospital Stroke Center find rewards every day, patients who recover, or new sciences which offer new hope for patients with stroke. The constant goal is finding ways to ensure stroke never happens.
What excites me are patients who are fortunate enough to get to us early enough where we know we can make a difference. And it's the ability to turn around a patient who could be severely disabled at onset, yet be able to walk out of the hospital a week or two later. When we hear that that patient has resumed an active lifestyle over the ensuing couple months, that's what makes it all worthwhile.
I hope that our job is really to help prevent stroke, that we will see in time that this rate of stroke in Connecticut will decrease, that we will know more about how to stop a stroke once it does begin, and what to do for patients if it does happen, so that we can get them back home.